and welcome everyone to today's webinar on acute heart failure, detecting, treating and managing it. So firstly, let's introduce myself. So my name's Ben. I've been a paramedic for 2 years and I first studied at the University of Worcester, completing my paramedic science foundation degree. Currently reading at the University of Cumbria in paramedic development, focusing on clinical modules, and I have a massive passion in acute and emergency medicine, including the Mental Capacity Act, and I absolutely love mentoring and teaching. And to finish it off, I have a cute, amazing little dog who looks a bit like an Ewok for those Star Wars fans, called Yogi. Yes, like the bear. And there he is. Look at that. If you've only come to see the dog, that's fine. So let's start with the main event, okay? So with any kind of illness, I always feel it is important to look at the pathophysiology of that illness. And today's pathophysiology is, of course, heart failure. So, for those who don't know and who are new, what is heart failure and acute heart failure? So, firstly, heart failure is that clinical syndrome. Okay, it is characterized by a variety of symptoms and signs. They see these few of these symptoms could be dyspnea, orthopnea, peripheral edema, and the signs be elevated jugular venous pressure, pulmonary congestion. Again, as well, we can also say peripheral edema for that as well. Most of the time, it's often caused by that structural and or a functional cardiac abnormality. Okay, so it results in that reduced cardiac output and or an elevated intracardiac pressure. So in essence, the heart is not working as it should be. The structure is poor, it's not there, it's not as a fresh, brand new heart should be. And then acute heart failure, so the sudden onset of heart failure, it is broadly defined as that rapid onset of the new symptoms, okay, or worsening signs, symptoms of heart failure. So for those who are diagnosed heart failure, if they've got worsening signs and symptoms of this, it is an acute heart failure. Same for those who are having a new onset of acute heart failure. So let's move on to the pathophysiology of heart failure. So as discussed, it can be caused by a variety of conditions. Okay, a few of these are myocardial infarction, heart valve disease, and congenital heart defects. And we have a little reference there from Story 2017. And all my references are at the back of this presentation. So as that heart fails, that cardiac output is decreasing and the preload is increasing. Okay, so as we know, the heart has two pumps to it. Okay, we have the left side and the right side of the heart. At either time, one or the other can fail, or both can fail. That myocardium will become weak and will result in an impairment of that heart to pump efficiently. Okay, so a lot of mechanisms are activated to compensate for that depressed ventricular ejection of blood. As discussed, that myocardium will become weak. And one of the most common forms of heart failure is that left ventricular or left-sided heart failure. Okie dokie. So let's look at this right-sided heart failure first. So right ventricular failure or right-sided heart failure can be caused by that pulmonary hypertension, so hypertension, valvular heart disease, so disease of the valves, and myocardial infarction. The ventricles will have that impaired contractility, so they're not contracting as they should be, so that cardiac muscle is not working as it should be, and the cardiac output declines. We will then see an increase within that right ventricle. Okay, so in essence, that pump isn't working properly. The right ventricle will have that increase in volume, so things will start to congregate within the right ventricle. And as we know, once something fills up, it overflows. That's going to overflow into the right atrium and beyond. Hence why we get the congestion within the the venous system. In right ventricular failure, stress on the heart from the carotid muscle reaches a critical level. We have that impaired contractility of that cardiac muscle and that output declines. Okay. Again, that backlog is coming through to the right atrium and vena cava, subsequently to the venous system. Hence why we get the signs and symptoms, which we'll discuss later. I got a nice little cartoon picture which I quite liked, which I found on Google. So we can have a look here. We see that the right ventricle isn't pushing that blood into the pulmonary system here. The lungs are like, nah, mate, can't take it, can't have it. So the right ventricle's like, oh, what am I going to do? So the right atrium's like, nah, it's okay, we'll just send it back. So it's going straight back into the rest of the body, hence why we get the ascites, renal failure, a peripheral edema, distended jugular vein, etc. As earlier, we discussed that if the left ventricle fails, we can also get right ventricular failure as well. So we get basically the whole of the heart is failing. So we see here, he failed because he failed. Same with the lungs. If the lungs aren't working properly, the right ventricle hasn't got nowhere to send it, so that's going to fail as well. Okay. If we move on to that left-sided heart failure. So left-sided heart failure has both the cardiovascular and non-cardiovascular causes. So the cardiovascular causes can be hypertension, mitral and aortic valve disease, arrhythmias, and myocardial infarction, same as the right-sided. Non-cardiac causes are pregnancy, childbirth, and thyroid toxicosis. So that myocardium is becoming weak, so that structure is becoming weak within the heart. And then with every beat, blood congregates and remains within that left ventricle. So we say a heart rate will increase to maintain that cardiac output, but with the heart increasing, blood is still continuing to build within the left ventricle. So we see an increase in hydrostatic pressure. So that hydrostatic pressure refers to that pressure that any fluid in a confined space exerts. For example, if a liquid is in a container, there will be some pressure on the wall of that container. In this case, it's going to be the blood within the tissues and vessels and the ventricles. This then, in turn, leads to one of the most serious manifestations of heart failure, which is pulmonary edema or pulmonary congestion and those wet lungs. Again, a nice little cartoon regarding left-sided heart failure. So as we know, left ventricle, as we know, has blood from the lungs. Okay, in LVF, it cannot meet demand and will send it back. Lungs become wet, that congested, that pulmonary edema, leading to these severe signs and symptoms. So with left ventricular failure, due to that lack of oxygenated blood around the body, we see low organ perfusion and hypoxia. Again, we have the ventricles are giving up, so the brain, the tissues are not getting the oxygen, so we're leading to low organ perfusion and hypoxia. We're seeing build-up of fluid in the lungs, which we're going to come on to now. So as I just mentioned, pulmonary edema, or sometimes known as that pulmonary congestion, or these wet lungs, is one of the most serious manifestations of heart failure. Okay, we see that fluid build up within the interstitium of the lungs and within the alveoli. So pulmonary edema, or cardiogenic pulmonary edema, has both cardiogenic and non-cardiogenic etiologies. So cardiogenic pulmonary edema is that result of abnormally high filling pressures within the heart and is frequently caused by that heart failure, as we discussed. The non-cardiac causes can be pulmonary capillary membranes, which is the involved alteration in the permeability of the pulmonary capillary membranes, and this can result from septic shock, toxins, fat emboli, and also high altitude. So this is one of my favourite pictures really, or diagrams from the Royal College of Emergency Medicine. It all starts off really with that left ventricle atrium is unable to empty the blood and send the blood through the aorta to the rest of the body. Okay, so we see a rise in end diastolic volume and pulmonary vascular pressure will increase. Okay, this moves down to the due to this pulmonary vascular pressure has risen, it will lead to that hydrostatic pressure exceeding the oncotic pressure. Fluid will then accumulate within the alveoli and interstitium. So we're starting to get a buildup of fluid within the lungs. So when that fluid has accumulated, this leak will overpower the lymphatic ability to reabsorb that fluid. This will then in turn hinder the gas exchange within the lungs, and the hypoxia will develop, and we will see an increased work of breathing. So we'll start to see breathing tachypnea to meet that demand. Hypoxia will trigger that catecholaminergic response, so we'll start that flight or fight response, releasing things like adrenaline, and we'll also activate the renin, angiotensin, aldosterone system, which we know which regulates blood and sodium within the renal system as well, and the body, blood pressure, I should say. So with that RAS system activated, this will lead to that salt and water retention. This will then make that left ventricle harder to empty. With that RAS, so the renin or angiotensin aldosterone system activated, there will be an increase in afterload and preload. Cardiac work is increased, and that demand for oxygen is further increased. So this is when we'll start to see tissue hypoxia. So after all that, we see that the ventricular emptying is massively decreased. Okay, more fluids building up, and getting worse and worse as this progresses. The relaxation is decreased and output is further decreased. So although there are multiple precipitating causes of cardiogenic pulmonary edema, congestion of the lungs, there appears to be two main groups which cause this. Those with that pump failure, so i.e. systolic dysfunction. Okay, so basically the pumps aren't working, the ventricles aren't working, and those with diastolic dysfunction and that preserved ejection fraction. So the latter group, like diastolic dysfunction, they normally are hypertensive and will have the left ventricle stiff, which are unable to relax. Okay. So in essence, basically, we're understanding the pathophysiology of this. We know how we're going to treat it and why we're going to treat it, which we'll go into later. But before we can even treat it, we need to detect it. And detecting heart failure is very, very difficult, especially pre-hospitally, because when we think of things like crepitations, we think of chest infections or peripheral edema. People might think of lymphedema. So detecting it is very hard. But we go back to basics whenever we assess a patient. So how do we decide it is heart failure and not something else? So have a look assess for them signs, symptoms of heart failure, which we're going to come into more detail in a bit. So for example, that peripheral edema, the distension of the jugular vein. Have a look at their medication list, their past medical history, their current diagnosis, and also discharge letters. I know nowadays with our EPCRs, we are getting access to looking at patient records. Again with consent is something to be mindful of. So history taking, let's take it back to the basics because it is something which is so important. We do sometimes forget, and know how I have at times. So Baid, 2016, one of the paramedic practice books, discussed that a systematic approach to that assessment will provide a lot of details to the clinician to have a systematic and thorough assessment to these patients. Nice and simple, an acronym, SAMPLE. We all heard of it, we all know what it is. So it's signs and symptoms, looking at the signs and symptoms of this patient, the allergies, the medication, what do they take, their past medical history, last oral intake. Please don't ask what the last oral intake was. If you get my drift, ask them what have they had to eat or drink. Okay. And the event, what's actually happened. Nice and easy. Doesn't have to be in that order, but it gets most of the information which we need to help make an assessment and to help us detect this heart failure. Another one which I like is Socrates. I know a lot of people say it's good for pain, but I also find it helpful using some of it to find a problem, a medical problem. So the site of the pain or problem, they might say, oh yeah, difficulty in breathing. Okay. What actually happened? What started first? The character. They might say, yeah, I feel like I'm drowning. It's quite a big indication. Radiation. Sometimes, yeah, we could use it for heart failure, but is it getting any worse? They might say, yeah, it's spread down to my tummy or something. Or the peripheral edema has moved into their tummy. Their associated symptoms, okay, what other symptoms are they having? And the time since the onset of this, what makes it better or worse? So they might say sitting up makes it better, lying down makes it worse, and the severity. I mean, it's again, that's normally for pain scores. However, we can use it if they've had it before. Compare it to before? Is it worse than previous? Better than previous? Helps make us a clinical decision as well with our decision making. Two simple acronyms, which we're all taught, in our first year of health, any healthcare profession, any assessment. But we take it with us throughout all of our clinical practice, and it really helps with every patient I find. So then, clinical features of heart failure. So let's have a look at the signs and symptoms of heart failure. Okay, so we have that dyspnea, so the shortness of breath, orthopnea, ascites, so that build-up of fluid within the abdomen, peripheral edema, normally it's pitting, okay, and to the lower legs, the lower extremities. They can have cold, clammy skin, cyanosis. So we understand the pathophysiology of cardiogenic pulmonary edema. We understand that they are going to develop cyanosis. Sputum, so pink within the terminal stages. That distension of jugular vein. Again, we understand the right side of heart failure. We know we see a build-up within the venous system. So it goes back through the vena cava, superior vena cava, and we get that distended jugular vein. We can see weight gain, so increase in weight from the lower legs, so from peripheral edema, from fluid. A lethargy, people are getting tired. Tachycardia, we know the heart is trying to compensate, same with tachypnea. Hypotension. Oliguria, so that less than that reduced urine output. I think less than about 5 ml per kilogram per hour. We can have a third heart sound, and then crepitations on auscultation, so that pulmonary edema. So this is from the European Society of Cardiology. Again, help us look at some of the definition of term signs and symptoms. We have your congestion, your left-sided, some of the symptoms here. Same with right-sided. For those who can do ABGs, we can look at hypoxemia, respiratory failure, hypercapnia, acidosis, and blood lactate as well. Okay, something to be mindful of for those working within a hospital-based practice. So a lot of people might not know or what they look like. So we all know our cyanosis, so blue tinge to the lips, to the fingers. We have the distended jugular vein. A lot of people say you can measure it. For myself, in these acute heart failure patients, you're going to be able to see that this vein is distended. As you can see here, it is clearly out and it's not as it normally should be. Ascites, so that build-up of fluid in the abdomen. We can use percussion to help us diagnose this. We have that peripheral edema and that pink frothy sputum. So with our patients, as discussed, they can get congested, and we can also have them as hypoperfused. Okay, so this little diagram here can help us decide whether these patients are time critical or not. So our warm and dry patients, so these patients are either wet or dry. So wet being congested, dry being not congested. So depending on their fluid status, and they're either cold or warm. Okay, so warm and dry, they are adequately perfused and hemodynamically compensated, so they're pretty well. Cold and dry, they are hyperperfused and possibly hypovolemic. Okay, just note it down here. So hyperperfusion it's not all might not always have hypotension, but the majority of the time they are going to be hypotensive as well. We have our warm, wet patient, the congested but well perfused, and our cold, wet patient. They're congested and hypoperfused. This is going to be our time critical and cardiogenic shock patients. Okay. So hypoperfusion is a condition of acute peripheral circulatory failure due to derangement of circulatory control. Can never say that word properly. And it could be a loss of circulating fluid as well. Okay. These patients are going to be looking well and be quite anxious as well. So how do we know if it's left or right sided failure? So we can look at our signs and symptoms of it. So left-sided, they're going to have pulmonary congestion because we understand the pathophysiology of left-sided. We know it backs up into the lungs. Hypoxia, as we know with pulmonary edema, it causes hypoxia and tissue hypoxia. Cyanosis, dyspnea, shortness of breath due to the congestion of the lungs. Nocturnal dyspnea and orthopnea. Right-sided, we have that jugular vein distension, again taking us back to the pathophysiology of heart failure. We see that peripheral edema, that venous congestion, ascites, renal failure, oliguria, and weight gain. Okay, so these are just some of the examples what we've discussed. But as we know, if the left side fail, the right side can fail as well. So we might have symptoms of both. So taking us back to the start of detecting it, looking at medication and the pharmacological treatments can help us to decide if they are in heart failure or acute heart failure, because a lot of times, sometimes we might have patients who are unwell, they can't talk to us due to the struggling to breathe, and they've got no one with them. So if we take a look at the whole picture, so we look at some of the pharmacological treatments, their medication. So they're going to be on loop diuretics, so furosemide and bumetanide are two of the main ones. They're going to be on diuretics, thiazide and thiazide-like, so they're also diuretics and can be used for hypertension as well. So that's benzoyl-flumethicide is the main one. Beta blockers, bisoprolol. Aldosterone antagonists, spironolactone is one of the key ones there. And we also have ACE inhibitors, so all three are ramipril, enalapril, and lisinopril. Okay, just by looking at the medications, it gives us an idea if this patient is does suffer with heart failure already, and they're having the worsening signs and symptoms of heart failure. So these are some of the pictures of the boxes of medication. Again, have a look at them, get hands-on with them, because as you can see, benzoyl-flumethicide and spironolactone both are quite similar, same with furosemide. So have a look at the patient's prescription list and also their box of medication. And then use people around you as well. Don't just talk to the patient. If they are with people, ask them about their past medical history. Look at their discharge letters if they have access to them. Look at their records. It all helps to create a picture of what this patient is suffering, and if they've got like the signs symptoms, they're on this medication, it can also point down towards that they are in acute heart failure. So what kind of assessments should we be doing? Well, we naturally do our physiological observations. We can do arterial blood gases if we have the capability to. Okay, so pre-hospital clinicians, majority of the time we won't be having that with us. Okay, we could do capillary blood glucose if indicated. So for me, I normally tend to do these if they're indicated. So if they've had a collapse, temperature can help see if they're cold. Okay, especially these patients who might have been really unwell, the collapse due to hypotension, might be on the floor for a while. 12-lead ECG, because as we know, acute heart failure can be caused by myocardial infarction. They might have a new onset of left bundle branch block, or they might be showing a STEMI, ST elevation myocardial infarction. We auscultate the lungs. Okay, so this identifies if there's any pulmonary congestion, any pulmonary edema. Okay, so then we're looking for bilateral capitations. Auscultate the heart valves. So we're listening for an S3 sound. So we have your lub-dub, normal lub-dub sounds, your S1, S2, and then sometimes we'll have an S3 sound, which is like a gallop sound. Okay, so a lot of time this is due to heart failure, and it's believed to be the result of vibrations of the ventricular walls caused by the abrupt cessation of ventricular distension and the acceleration of blood entering the ventricles. And we can also use echo as well to help us diagnose, have a look at the ejection fraction of this patient, have a look at the ventricles as well. So let's move on to treating heart failure. Okay. So we'll have a look at some guidelines for treating it. And one of the key ones, we all know what I'm going to say now, is NICE. So what does NICE say? So the NICE guidelines, they're based on evidence-based practice, and it's something which everyone goes off really. So we offer IV diuretic treatment. They discuss using nitrates in special circumstances. So this could be where patients aren't responsive to diuretic treatment. We do not routinely offer morphine and nitrates. We'll come on to morphine in a bit. And we offer non-invasive ventilation and oxygenation, okay, to help with the respiratory symptoms. Our other guidelines, which I found really good, is the European Society of Cardiology. We use vasodilators, so we use our nitrates, so GTN is one of the main ones. Use of IV diuretics, oxygenation, vasopressors for our cardiogenic shock patients, our hypotensive patients, and like NICE, opiate use is not recommended. Both quite very similar in what they say, is recommended. And then for our ambulance colleagues, we have ACUL. So as we know, we look for identify that acute heart failure. It recommends oxygenation, intravenous furosemide, use of GTN. Again, also discusses avoiding use of morphine and use of CPAP if available. So that non-invasive ventilation. And we have a nice little urgency of transfer. I normally say from here to here is our time critical patients, and these patients need rapidly get to hospital. Okay. Again, discussing the examination of what we discussed earlier and the history. So this is a nice diagram from the European Society of Cardiology, and I like it. It's nice and simple. It really covers a lot of all practices, so from pre-hospital to hospital. We have that identify that patient has acute heart failure. With all patients, we assess our ABCDs, airway, breathing, circulation. Okay, assess their hemodynamic profile. We move down to if they have congestion. So are they wet or are they dry? So most acute heart failure patients, they're going to be wet. They're going to have that congestion. As we know, wet is that congestion, dry is hyperperfusion. So congestion, pulmonary edema is the main one we're looking at here, but it can also include your peripheral edema. And dry is hyperperfusion. We move down to our wet and cold patient. Okay, this is our cardiogenic shock. And we move down to if this is wet and warm patient and discuss the treatment. So we commence treatment with IV furosemide and GTN, so vasodilator and diuretic. Same for our congestion. A lot of time we're going to have hypertension with these patients as well due to that activation of the RAS system. And for our wet and cold patient, we commence that treatment. So firstly, we reverse the perfusion. Okay, so once that perfusion is corrected, we commence that diuretic treatment, and we can look at using vasodilators for our patients who are not hypotensive. Okay, as we know, GTN has an effect on the blood pressure. So the medications which we can administer. So for the ambulance staff, and as well as hospital staff, it is glycerol dry nitrate, can either be as sublingual or an infusion. For sublingual, for our pre-hospital colleagues and hospital colleagues, it's 400 800 micrograms sublingual. Okay, we have our contraindications from our JCALC and the BNF from hypertension, head injury, the unconscious patient. Please don't spray into their mouth if they're unconscious. It's not good. Head trauma and cerebral hemorrhage, Viagra, so sildenafil and other stimulating medication, and we have that known severe aortic mitral stenosis. As we know, cautions suspected posterior right ventricular infarction. Furosemide, that's 40 milligrams intravenously. So contraindications, that cardiogenic shock, it's actually not a contraindication within the BNF, just to point out. Renal failure with anuria, so not producing urine. Reduced GCS with liver cirrhosis, children under 18. It's also to make note of patients with hypokalemia and hyponatremia. As we know, furosemide affects, we'll come on to the pharmacodynamics of furosemide in a bit. And cautions our hepatic impairment, hypertensive patient, and that pregnancy and hypokalemia, as we just mentioned. So if we understand the pharmacodynamics of these drugs, we understand why we give them. I think this is something we should all do for all of our medications which we administer. So furosemide, it is a loop diuretic and it acts principally on that ascending limb of the loop of Henle. Okay, it will inhibit, so it will stop that sodium potassium chloride co-transporter. So it will stop the protein which is responsible for the transportation of sodium potassium chloride ions from the tubular lumen into the epithelial cell. This will have a potent diuretic effect and also helps dilate in the capitance veins. Within acute heart failure, it reduces preload. They take us back to our pathophysiology. It reduces the preload of the heart, so helping the heart relax and taking that pressure off. And we have an onset of effect is within 5 minutes, and that peak effect is reduced within 30 minutes. And then following intravenous administration, it normally lasts for about 2 hours. Okay. GTN, glycerol nitrate. So nitrates are converted to nitric oxide. Okay. In essence, it reduces the intracellular chloride and chloride ions, and the vascular smooth muscle cells relax within the heart. This results in that venous dilation and, to a lesser extent, arterial dilation. But if we have arterial dilation with sublingual, we've given a lot of GTN. It will decrease that ventricular volume, therefore that decreasing the wall tension, and will a subsequent myocardial oxygen demand will decrease as well. It's basically making the heart, telling it to, well, hold on, relax, slow down. So the sublingual route has an onset of 1 to 3 minutes, and that duration of action is 15 to 30 minutes. Morphine. So morphine, so a study from Ellingswood discussed that use of opiates can increase adverse events. The main one being mortality. But we can use morphine for cautiously for patients where this chest pain isn't eased with nitrates. I'm talking about 2.5 milligrams of morphine. One of the studies which I found, which was in 2020, so morphine therapy was associated with a significant increase in the need for subsequent invasive ventilation. So morphine therapy was also associated with a significant increase in the use of inotropes, non-invasive ventilation, and acute kidney injury. Furthermore, within this study, they observed that there was a significant direct relationship between morphine dose and the endpoints of the need for invasive ventilation and also mortality. So this is going off the reasons really why we avoid morphine within heart failure, in acute heart failure, due to that risk of that increased adverse effect of mortality. So let's have a look at the evidence-based practice of managing, detecting, and treating heart failure. So the prognosis is poor for patients with acute heart failure. However, if we have the correct management of these patients, it can result in the ease of symptoms and make these patients more comfortable. Again, going on to a study from Purvey, he highlighted the use of nitrates, diuretics, and oxygen therapy for patients presenting with congestion. This was also supported by Parasius, who also supported the use of oxygen therapy because these medications treat improved symptoms of these patients. Powell in 2017 included the use of oxygen therapy and how NIV, so non-invasive ventilation, and such as that continuous positive air pressure, significantly relieved a lot of the main respiratory symptoms of respiratory distress, the main one being dyspnea, that shortness of breath, and that tachypnea. One of the key things, well, which I know ACUL discusses, is to administer furosemide when there's a prolonged time to hospital. There was a few studies which have said that early administration of furosemide is beneficial, and when furosemide is administered sooner, it has been shown to prevent increased stays in hospital. Again, another study that early administration of furosemide was also identified in a different study to reduce that length of hospital admission as well. Okay, that's one of the reasons why we can, we think actually let's get furosemide on board sooner rather than later. So managing heart failure, again, we're taking it back to our basics really. We identify that this patient has acute heart failure. We're going to stabilise that patient pre-hospitally. Okay, we're going to commence the oxygenation and commence the acute heart failure treatment as we've just discussed. So that's sublingual GTN, intravenous furosemide. We're going to extricate, attempt to keep them sat up. We don't want them lying down. It's keeping them sat up, help with their breathing as well. We're going to pre-alert the receiving hospital, preferably a cardiac centre, somewhere with a CCU, so a coronary care unit, okay, and cardiac capabilities. And we're going to be constant reassessment and further treatment, getting them to hospital. Okay, nice and simple. We keep it down. We keep it very simple. Let's not get entangled with things. We're going to offer oxygenation, and if we can't get IV access, because I know sometimes we just cannot, and as long as the blood pressure is okay, just that GTN, as we've understood the pharmacodynamics of it, can help reduce that preload of the heart and help relieve symptoms, especially dyspnea. So on the arrival at the emergency department, we hand over. Now, depending on the clinician who's dealing with it, they're going to manage this patient with diuretics, possibly a GTN infusion, oxygenation, so that NIV, inotropes or vasopressors if needed. They're going to do their assessment, they're going to do the ABGs, their bloods, their physiological observations, looking at scans such as chest X-ray maybe, echo. They're going to be referring to cardiology or medics and most likely be admitting this patient to the hospital. So have a look at a quick case study regarding a patient who's presenting with acute heart failure. So it's a category 2 call for 56-year-old male with difficulty in breathing. That's all we get on the CAD. We get a lot of details where a lot of patients where we don't see much on the CAD. We find out information when we get there. So we're going to be finding a cold, wet patient lying supine. He's had worsening dyspnea over 5 days, and he's producing that pink frothy sputum. Okay, the initial primary survey finds that he's tachypneic, tachycardic, he's confused, he's got altered mental status, and he appears very pallid, clammy, and cyanotic. Our observations are as follows: as we can see, tachypneic, low oxygen saturations on room air, tachycardic, he's hypertensive, and he's got normal capillary blood glucose. So what do? We take it back to our pre-hospital management. We stabilise that patient by assessing how they've got heart failure. So again, looking at their past medical history, their medications they take, their signs and symptoms. So we're going to be looking at are they got congested lungs, heart sounds, so S3 sounds, looking at the peripheral edema, any distension of the jugular vein. Using all this to collate a detailed picture for our patients and ensuring that we are going to go down the correct route. Okay, it's one of the big things. If we are going to diagnose something, we want to be able to show that we can treat it as well. So if we're going to say this patient has acute heart failure by the signs and symptoms are presenting with, we've understood the pathophysiology, we understand how it worsens, how it develops. We know the signs and symptoms of it. We can happily say that this patient is in acute heart failure. So we're going to commence treating with the IV furosemide. We can give the GTN. We can give the furosemide because we've got a hypertensive patient. In turn, the GTN will help reduce the blood pressure as well. We're going to be managing the congestion, so we're going to be reducing the preload of the heart, hopefully increasing the oxygenation as well by giving oxygenation. And we're going to be getting them to the hospital. We're going to be pre-alerting that emergency department and getting there safely, but a progression made on alerting. Really, it is really simple to follow nice algorithm, as we've just seen from ACUL, the European Society of Cardiology, NICE guidelines. Acute heart failure is out there. It's predominantly patients we're going to be seeing are going to be having worse symptoms because it is really well managed within the community with heart failure nurses and with primary care. But sometimes these patients are going to get worse, and it might be suddenly, it might be gradually. So the most patients we're going to be seeing are those who are in acute heart failure, and they are going to be unwell. So we want to be able to ensure that we can detect it, treat it, and manage it. So these are my references, which I've used to collate all my information, which I can pass over to Andrew to give post out there. So all my references which I've used on 2 pages as well, and we've also included the BNF for the drugs. So in essence, that was a nice little whistle-stop tour on acute heart failure and detecting, managing it, treating it. Hopefully it's been a bit beneficial. This was my first ever CPD-Me event. Always welcome feedback from yourselves, and hopefully you've understood me and my Brummie accent, because if you haven't worked it out, yes, I am from Birmingham. Yes, it is the best city in the country. So yeah, I'll pass it over back to Andrew and we'll take some questions now.
Hi, I'm Stephanie from CPD-Me, and welcome to our webinars. Taking part in our great CPD webinars is an excellent way to learn new skills and knowledge in an informal way, either whilst at work, relaxing at home, or maybe enjoying some downtime in the park. Our webinars are designed to support our learning community, to work and learn in a relaxed and informal environment. And the great thing is, if you're a member of CPD-Me, you can replay and watch these back whenever you like. Registering for a webinar allows you to attend the live event and interact with other viewers online, sharing both learning and links. Don't worry if you can't make the live broadcast because you're running out of time or get a late job. Simply register and we'll email you a fully edited copy of the broadcast the following day. Members of CPD-Me receive a free CPD certificate for watching both live broadcasts as well as watching previous webinars. Premium members also have access to a personal CPD dashboard that contains priority booking for all our live webinars, plus over 500 CPD webinars and seminars on demand to watch whenever you choose, with automated CPD certificates. You can always purchase a CPD certificate if you're not a member, but it is more beneficial for you to join CPD-Me and take advantage of all the benefits. One great feature of membership is that you won't have to pay for every certificate, and we will automatically add a copy into a professionally formatted CPD portfolio, accessible via your CPD dashboard for all our mobile apps. Join today, and we'll backdate any webinars that you've watched within the last 14 days. Now is the time to take charge of your CPD. Now is the time to join CPD-Me.